Good morning. Happy Monday. I have Neuro Coffee in hand and it is perfect. All right. Coming up on a very busy Monday, an unusual Monday, but we will get it done. A quick housekeeping item, IFAST University, we have a call today at 1 p.m. Eastern Standard Time. If you are not a member of IFAST University, please go to ifastuniversity.com, get yourself signed up, and join us for the 1 p.m. Eastern Standard Time call. We're going to dig straight into today's Q&A. This was Zhang. Zhang asked a great foundational question in regards to connective tissue behaviors. And so he still has a question in his mind as to how we influence connective tissue behaviors in the relationship to muscle output. And so this is one of the reasons why we have to consider direction of gravity and body position and such, because we have internal and external forces that we have to manage. This is going to tune up and tune down motor output, which is also going to influence and tune the connective tissue behaviors. So a great question, Zhang. And like I said, we covered a lot of ground here in a very short period of time. I hope it clarifies this point for a lot of people. Everybody have an outstanding Monday, and I will see you tomorrow.
So I have a series of mini questions about muscle activities and connective tissue behaviors.
Is this like an Alex series of questions?
Not, I don't think so. Probably shorter than that. Okay, so so you talked about in the last week, you talked about with Manuel at the bottom of the squat. So the anterior pelvic outlet is eccentrically biased.
Until you hit the bottom.
Yeah, in the bottom of the squat.
Until you hit the bottom.
Until you hit the bottom. And you said the reduction of the muscle activity will increase the yielding potential of the connective tissue.
Reduced motor output. So it's not the orientation of the muscle, it's how many motor units are active.
Okay, I guess that's one of my mini questions. Is there a difference between orientation and
do that?
Yeah.
Do that. Okay, look at the angle. See it? Push on it, but don't let the arm move. Okay. Do you feel the muscle working harder?
Yes.
Did you change the joint angle?
No.
Okay. So you increased the motor output, but there was no orientation change. See the difference?
Yeah.
So one had more motor units active than the other, but yet the orientation was the same.
Okay. So if I put this concept into practice, so when I see someone whose center of gravity shifted way forward, and I lie him down, he will reduce the motor output, right?
Potentially.
Potentially.
One of the reasons. That's one of the reasons why you
change.
Hang on. That's one of the reasons why you might lay someone down to do an activity, is because you're taking gravity out of the equation, so they don't have to use so much motor output. But that doesn't guarantee that they will reduce the motor output sufficiently.
Okay.
Okay.
So does that?
They're learned behaviors. These are learned behaviors. So I could take somebody that stands in a late propulsive representation, lay them down, doesn't guarantee me that they're going to go into an early on me, right? They can still be utilizing the late propulsive strategy, right? And I still have the interference.
Okay. So how would you reduce the muscle activity enough to capture the early representations when you lie down? Well, so is that a matter of somebody is not relaxed enough in that position?
You could look at it. You could look at it that way. I would hesitate to use a relaxed term, because if I'm setting someone up in, let's just say I'm putting them in a hook lying activity, because when they stand up, they can't reduce the motor output. So I lay them on their back. So I'm capturing certain sensations that would promote a shape change that would, and muscle activity that would allow me to access the connective tissue behaviors that I want for an early propulsive strategy. Okay. So again, it's a combination of factors. It's like, okay, I got to deal with gravity. I've got forces that are inside of me that I've got to control. I've got forces outside of me that I've got to control. If I can capture the right sensation, so that might be a foot contact, that might be a pelvis contact on the table, right? That might be the way that I inhale and exhale. Like all of those things come into play to promote the desired output or behavior, right? Mm-hmm. So that's what we're doing, is we're trying to provide the appropriate inputs to get the behavior, right? We want the right outcome. And so all we're doing is manipulating the influences. Some people can do it standing up right away. Some people can't. Some people need manual therapy to feel what we want them to feel, so they do create the right output.
Good morning. Happy Tuesday. I have NeuroCoffee in hand, and it is perfect. All right. My weird and wacky week continues. We are going to dig straight into today's Q&A. This is with Peter. Great foundational question. The overarching principle that we're going to cover in this question is you're going to move in the direction of expansion. This is a universal principle. Doesn't matter what we're talking about, but the general premise is that. So whether we're talking about a synovial joint, whether we're talking about any sort of shape change, you're going to move in the direction of expansion. And so this is some of the fluid dynamics that we often talk about in regards to how we might roll across the ground, how we walk across the ground, etc. So again, great foundational question from Peter. So Peter, thank you so much for asking this. It will help a lot of people. Everybody have an outstanding Tuesday, and I will see you tomorrow.
Hello, good morning. I wanted to talk about the water balloon concept and how that relates to a joint position and how that relates to center of gravity. So water balloon, if you compress one side, fluid shifts to the other side, right?
I'm aware.
Right, yeah. So if you're looking at that in the context of two bones that are on top of each other, if you're compressing one side, the fluid's shifting that way.
Draw this picture all the time, Peter.
So that means that the person's heavier on this side because their bones are getting closer together and their shape overall is changing into that direction.
Yes, so there'd be expansion in the opposing direction. So your compression would increase where you brought your hands closer together.
Okay.
This is a two-dimensional representation of a four-dimensional problem.
I know, yeah. I just need to keep it simple.
No, I'm with you. That's why we draw flat pictures, because it does make it simple. So go ahead.
So the person's center of gravity has shifted from my perspective, it's that way. No. Where is it then?
Okay, you've been on the call the whole time, right?
Yeah.
Simple rule. We were just talking with Robbie on the golf swing. Simple rule.
You move in the direction of expansion. Oh, that's weird.
Oh,
okay.
Bend your elbow. Bend your elbow. All the way. All the way. Okay. What direction did your elbow move?
I guess my elbow moved that way.
That is correct, sir. Don't be distracted by the sharp, shiny objects. Right? Everybody looks at the bony position, right? And they go, no, my arm's moving this way. It's like, no, that's the direction of movement.
Well, because if you did move this way, then you would fall that way, I guess.
Yes.
Okay.
So if I IR the lumbar spine, is the pressure posterior or anterior?
You're applying a posterior pressure
with an expansion forward, so that's the direction you go.
Okay.
You get it?
Yeah, I think so.
Yeah.
if you're trying to influence that situation where you have expansion on one side, compression on the other side,
Yes, sir.
generally speaking, you're going to apply a compression to the expanded area in order to try to get this to happen.
Yes, sir.
And you can do that with manual therapy or activities.
Or an
whatever.
exercise, or yeah. Say the magic words. Sometimes it works.
Cool. Okay, yeah, that helps.
Yeah. So when you were in school and they taught you about end fields, remember those?
Mhm.
Right. And I honestly, I don't even remember most of them. Stanley Paris has 16 different end fields, but yeah, I know. Well, that's it's the boggy and the mushy and the squeezy and the oatmeal-y, and I don't know what they are. Right. They're just a bunch. Jordan probably knows all these end fields. Right. But this is what you're feeling. So you're feeling the connective tissue behaviors, and then where the fluid shift takes place. So when you get a really hard, abrupt end feel, assuming that the joint constraints are within some sort of normal representation, you're feeling the water in the joint compress and it becomes solid, right? That's a hard end feel. It's like, so that's how you can tell, where you are. So, when you hit the end range of something and it does not move past, and it's supposedly within what they would consider the average ranges by textbook, it's like, you've just created, like, literally you've moved into a space that no longer exists, because you just compressed everything.
That's analogous to maximum propulsion.
Potentially.
Okay.
Yeah. Depends on where you're.
I had another quick
Depends
question.
where you are, because think about this. It's like if I'm doing an Ober's test,
Mhm.
and they don't have any internal rotation, it's because the fluid content is medial to where I'm measuring, or posterior, depending on the limitation of the test, right? So let me use a traditional hip extension. Okay, why doesn't the leg come back? And people say, well, you've got muscle activity on the front side. Yes, but it's the fluid pressure moving posteriorly. It's the fluid volume, rather, moving posteriorly that creates the interference to the movement. It's not the muscles. Muscles are just keeping it in a certain space. It's like when you lift weights and stuff, you're stacking weights on a column of compressed water.
Yeah, you said that once and it blew my mind.
Yeah. Pretty cool when you think about it that way, though.
Mhm.
Are we good?
Yeah, I think so.
Awesome.
Good morning. Happy Wednesday. I have Neuro Coffee in hand, and it is perfect. All right. Today is Wednesday. That means tomorrow is Thursday. That means tomorrow morning, 6 a.m. As usual, coffee and coaches conference call. Join us for some great Q&A. Grab yourself a cup of coffee. Great way to start off your Thursday morning. So please join us for that. Digging into today's Q&A, this is another segment with my conversation with Pat Davidson on his podcast. Probably a really good one for the young coach to listen to. This has a lot to do with how we work in this mentorship apprenticeship model successfully to teach us how to deal with uncertainty, managing our failures and such. You are going to face this. You might as well do it in a very safe to fail environment. And so again, a very useful conversation for a lot of young coaches. So again, thank you, Pat. I'm not sure when the full conversation is going to be up. That's up to Pat, but so keep an eye on that if you're interested in hearing the whole thing. We had a great time. It's very fun, so I think everybody will enjoy it. Have an outstanding Wednesday. I will see you tomorrow morning, 6 a.m. Coffee and Coaches Conference Call.
Well, there's more comfort in certainty.
Of course there is, but there is no certainty. But there is no certainty. See, that's
perceived certainty. Yeah.
Well, it's protection. It's self-protection. Like if I am certain, then I am comfortable, I am confident, and I feel good about myself. And it's like, but the minute you can start to accept the fact that things are uncertain and you're playing the probabilities, then there's a level of comfort with that too. And that's where I think confidence comes from. And that a younger coach or therapist does not have, because they haven't survived
enough failures, right? And I think that's a big deal, because you have to be comfortable with the uncertainty. You have to be uncomfortable with the not knowing. And again, you are playing probabilities. It's like, you know, if you're, you know, 82% correct, then that's a pretty high level of confidence, but with the understanding that there's still an 18% chance that you're going to fail. And then you have, again, get comfortable with it. It's because it's going to happen no matter what you do, no matter how good you are, no matter how great a diagnostician you think you are, you're the best interactor, you're the smartest guy in the room, kind of a thing. Yeah, you're going to fail because you're dealing with another human being.
Well, it's a beautiful way that you put that. And I think that it's, you know, fairly universal. It's not just within the scope of physical therapy or fitness or any of those things. It really is, you have to get to the point where you realize that you're going to be okay, even if this thing falls apart.
Right. But you have to have that experience.
Yeah. Yeah.
And you know, if you, I know your dad, right?
Mm-hmm.
So if you don't let the kid fall down, scrape his knee, get a little dirty every once in a while, he's not going to know that it's going to be okay.
And I'll tell you, it's an era where other parents don't seem to want to allow that to happen.
Yeah.
And you know, my caregivers when I was very young were born in 1914 and 1915 respectively.
Nice.
And you know, they certainly didn't have the helicopter mentality. And it was almost like, what are you doing hanging around us? Go out in the dirt. Like,
right, exactly.
So I find myself being at these urban playgrounds, right, and having more of a depression era mentality.
Right. But see, this is the thing. It's like, so again, for the younger coach, younger therapist, it's like we're talking about the same thing. It's like for them to get dirty means that they have to put themselves in situations that are uncomfortable, where their decisions may not be the best choice. And we do that in a safe manner. And that's through the supervision, if you will, of a mentor, working as an apprentice, right? That's where you do your safe to fail experiments. But again, this is where you learn that, okay, I'm not always going to be right. This is not always going to be the best choice. It is not always going to have the best outcome. We have these discussions, you know, and it's always best case scenario. It's like, oh, you sound like the greatest coach in the whole world. You sound like the greatest therapist in the whole world. And then if somebody followed you around for a week and they would go, wow, you really screwed that one up. It's like, yeah, I did. But you know you're going to survive it, right? Because you've got the experience that, okay, yeah, I've screwed this one up before. I do it a lot less than I ever did. Right. But it still happens because, again, it's like anytime you're interacting with another system, it's like you have no idea what their response is going to be. And again, just getting comfortable with that takes time.
Right.
Good morning. Happy Thursday. I have Neuro Coffee in hand, and it is perfect. What's going on?
All right. So I've got a question. I've got a million questions, but let's start with this one. I was reviewing some of the intensive Zoom calls through the history of the page there, and I noticed. I noticed that you were coaching a little while back a prone breathing position where you essentially just put a pillow under the pubis and then the hands into almost similar to the frog representation, except with the pillow underneath, coaching the breathing. And I'd been playing around a little bit with that, and I'm just trying to get some clarity on exactly what I've been seeing, making sure that is in fact sacral nutation and counter nutation, because obviously I can't put my hands on someone to feel that, so I go visually. And what I've been seeing at this point pretty commonly is that when they start the drill, we get a bit of, you know, sort of lumbar expansion, and then it seems to progress down, and we'll see the butt, I guess, if you want to call it that for a better description, kind of rise and fall. And then as it goes a bit further, we get it doing this just a little bit. And I'm presuming that is sacral nutation, counter nutation, without being able to put my hand on it observationally. It looks like
Yes.
it. Is that on track?
Yeah. Yes, sir.
Cool.
Yeah. What this is just a great representation of the systemic response to the change in volume.
Yeah.
So when you breathe in, if all relative motions were accessible, the entire system progressively externally rotates.
Yeah.
Right. And so what you're seeing, what you see is you see the expansion associated with the inhale, and then you just see it propagate throughout. And it's like, it's really difficult to see your fingers externally rotate, right? but the premise that I want you to understand is that you, like, literally this thing just spreads out, and then as you exhale, the compression then resolves, just like if you were standing on the beach watching the waves come in and out. Right?
So with your experience, when you I've got some pretty decent end game narrows that I've been trying this on. Does it normally take them? Do they get better at it over like with practice? As far as, at the moment, it's taking them a few minutes before we start to see that effect take place.
Mm-hmm.
If making changes correctly, then we should hope to see that decrease in time as they get along. Is that generally how that works?
Maybe. So this is where contacts come into play. This is where muscle activity comes into play. This is where shape change comes into play, right? So if you have somebody that is compressed anterior posterior, which means that they're expanding laterally, right? And you're putting them in a flattened position, you may not get the response that you want just by putting them there and hoping for the best. What this would be, though, is from a representation standpoint, it may actually help guide your process. It may allow you to identify when it's not propagating, right? So you can use it as a comparator.
Yeah.
Versus don't just put somebody there and then expect everything to be all fine and wonderful.
Oh no, I'm just looking for some. Yeah. No, so like someone that you're just describing there, the ideal, I guess the ideal sort of progression to that would be look at a side-lying activity and then perhaps go back, retest that.
It's no different than any other activity in regards to, like, okay, I'm going to perform this. We're going to observe. We're going to see what happens. We're going to measure however we do that, and make the comparison, and then we continue the process. Right.
Okay.
Yeah.
Cool. Well, that was my quick question. Now I have one that is a shade, probably equally as quick for you, but a bit longer for me. So I'm seeing someone that when we get a representation, I've seen this more than once, where someone moves into a split squat type activity, and they're getting no pain if they've got in the knee if they have a leg in late. So when the leg's behind them and they descend from late to middle, they're getting no pain in anterior slightly medial knee, and yet go from early to middle, so as in front foot descending into a lunge, for instance, they're getting pain associated with medial knee.
At what point?
So pretty much as they're getting toward middle, so just
so near the bottom of the split squat, they have lead leg, anterior knee pain.
Yeah, lead leg, anterior knee pain. Now they can execute a squat. Now I presume for the same reasons that they're not getting it moving from late to middle, because the top of the squat is late to middle. They're not getting the knee pain there, so that's pretty consistent with having that representation on the rear leg in the split squat. But as soon as we early to middle, we're getting that pain. Now, I'm trying to imagine in my mind why it's occurring at one point but not at the other. The wave's moving in the opposite direction. but from a internal external rotation, like if we've got a tibia that is, you know, externally rotated relative to an internally rotating femur,
Yep.
then that's going to be consistent in both situations.
Oh, it's
But
already on. Oh.
Okay, but it's not the same. But it's not the
no,
same.
that's what I'm trying to get in mind as to why it would occur in one circumstance, not in the other.
Right.
Yeah,
Okay.
okay.
So, all right. Somebody needs to mute, please. Thank you.
Okay.
Or not. Vic Somol, can you mute? Thank you. So the difference between the two, okay, in regards to the descent of the split squat. So both are internal rotation representations. However, it is the direction in which the energy is moving. So you store and release energy as you would take a step forward. So you land on the ground, you absorb energy, you move over the foot, you push off the ground, you're pushing into the ground. So again, you take energy out of the ground, you push it into the ground. So early to late, correct?
Yeah.
Okay, good. So that's what our split squat looks like. Okay. So I can't speak intelligently about why they would not have it in the later representation, because there may be something that they're doing that I would observe that would help me identify this. However, you do have a big clue in regards to where they're experiencing the knee pain and in which leg. So you have a situation where as they're moving into a more internally rotated position where they have to absorb more energy. So as you descend into the split squat, that is an early IR representation, which means that internal rotation is coming up from the ground towards the pelvis to make the shape change. Okay. Mm-hmm. And so you have an interference at the knee that is not allowing this internal rotation to propagate proximally. It is stopping at the knee, so to speak, right? It is interfering at the knee. Most likely what you have is you do not have the internally rotated representation at the knee at the time of the discomfort. Okay. Yeah. And so this could be the foot position. This could be the fact that the tibia is not able to internally rotate sufficiently relative to the femur to access the internally rotated position, right? Mm-hmm. Or you have top-down interference. So you have ER that comes down from the top, you have IR that goes up from the bottom, and you may have too much of an ER representation proximally that is not allowing that shape change to occur. And so once again, you have the interference below that level, and it's stopping at the knee. All right. So again, what I would do, Matt, is I would make sure that, number one, you've got access to the appropriate foot position. You got to make sure that you've got the tibial IR available to you, and you got to make sure that you got the hip IR available to you.
Yeah, I've got a pretty good plan for trying to remedy it. She's heavily anteriorly oriented, which is not helping it. There's other things going on, but the difference
between you. But the fact that she's okay in a bilateral squat, right? Mm. Okay. So the way that the IR comes up through the extremity, goes straight up through the extremity, goes to the hip, and then it goes towards the middle of the pelvis. Okay. So it goes up like this, and then towards each other with the bilateral symmetrical activity.
Right.
Okay. In a split stance, it actually goes right towards it comes up through the extremity and it aims right towards the pelvis. So there is a slight difference in the directionality of the of IR that comes from the ground up. So again, I'm leaning towards the fact that when she's in it's a she. When she's in a split stance, that she's not able to make the shape change from ER to IR proximal. And like I said, it's coming down, so to speak, from the pelvis through the femur. So you probably want to look proximally first. Yeah. Okay. And then again, make sure that you have all of your foot contacts as well. Okay.
Yeah. Okay. Well, that makes sense why we might not see it in the squat if that's if it's changing direction from relative to the split squat, it's coming in at a slightly different direction.
Yeah, there's
Yeah.
a change. There's a change of angle as to how the internal rotation propagates.
Yeah. Okay.
Good.
Good. Very good.
Good morning. Happy Friday. I have Neuro Coffee in hand, and it is perfect. All right. For those of you on the 2-week sprint, this is your recovery and reflection weekend. Make sure you are on point with all your goals and aspirations, and you are making progress towards them as appropriate. Digging into today's Q&A, this is with Robbie, and Robbie was questioning some of the approaches on how to alleviate some of the concentric orientation that we talk about. All of these superficial muscle strategies tend to be biased towards exhalation. We're trying to create expansion where we've had compression, but there are some issues associated with that if we don't have a practitioner that can help you with manual therapies and such, then we have to come up with strategies that will allow you to do this yourself. And so this is why we use ground contacts and then some of the associated tools such as foam rollers, lacrosse balls, etc. Using some of these techniques, we can actually reduce some of this concentric orientation and then allow us to promote the expansion, create a gradient, which then allows us to restore relative motion. And there's a little kicker at the very, very end, a very, very important point. So make sure you watch this video all the way through. Thank you, Robbie, for leading us in this direction. Podcast will be up on Sunday. Everybody have an outstanding Friday. I'll see you next week.
So, question for today is, I need you to untwist me, as you well know.
Yeah.
So it's funny because the more I'm getting deeper now into the model, the more the words you said to me 4 years ago keep ringing in my head. In the purple room, you looked at me and said, "You're spinning." So it's starting to make sense now why I'm spinning. But just in terms of narrow, compressed, and training recommendations, like I'm just at a stage where I'm like, right, I'm kind of done being very bad to my body. So I obviously do need expansion, and I'm still working my way through the type of exercises I should be incorporating. But what are some of those recommendations for narrow compressed? I know what's off the table: bilateral pressing, overhead pull downs, bench, and all that should be gone. But what else should I be incorporating to sort of recapture some expansion?
Well, under most circumstances, the superficial musculature is what creates the progressive increase of exhalation based muscle activity, right? And so you have to recapture your ability to expand the ERs. So that's the reduction in concentric orientation. So activities that would do that. So this is one of the reasons why I like to get people down on the ground and roll them around so much, is because it's like getting manual therapy done. Right. So for you to roll effectively, you have to be able to reduce concentric orientation to do that. And so getting down on the ground, and we're talking about like the infinite number of ways to roll around. But this might be where you also need to get a little bit of help from a practitioner of sorts that can help you reduce that. And then it's a matter of follow up with activities that promote the expansion. In most cases, because the compressions are anterior and posterior, this is why side lying, short arc rolling, and things like that is a great place to start for most people, because it does allow them to conform to the ground. The internal forces are reduced because you're side lying. You're going to get anterior posterior expansion associated with the gut position as they're basically falling towards the ground as you're rolling around. So those are the beginner activities. If you got to do this on your own, it's like you got to get down on the ground. You got to start moving around. You got to learn how to conform and relax into the ground versus thinking about force production and such.
Yeah,
right?
yeah.
That's where you're gonna have to start. And this is where you break out all the old school stuff, like foam rollers and lacrosse balls and anything that's pokey and proddy and all that kind of stuff. Because first step is you got to reduce the muscle activity that's creating the interference in the first place.
And in terms then of just like dorsal rostral, would I just be the exercises you have out there in the YouTube? Would you incorporate those for me too? Because obviously that's very compressed on me.
Yeah,
Okay.
but you wouldn't do that. You wouldn't do like that first thing walking into the purple room. You would be you would have to create a gradient first. See,
Okay.
here's your problem. So this is the problem with that's associated with a lot of these people that are very, very compressed, is that they just don't have a gradient for movement to exist in the first place.
Yeah.
And so you have to create that. And like I said, the best way to do that, again, if you have to do it by yourself, which is really, really difficult, is through like I said, the pressure of the ground and gravity, just to start moving around and rolling around. And it starts to look like, phys ed class in the 2nd grade, right? Rolling around on mats and stuff.
Okay. Yeah. Okay. And just one last little thing to that. In my mind, I just had this thought, but now that you're saying about it's more about attacking the concentric orientation first, I had this thought in my mind, it's just with expansion where I'm compressed. I was like, from a training perspective, because I don't do a lot of activities that put me into any heavy type of breathing patterns. And in my head, I was like, I wonder, because I used to do a lot more of that, and I was less compressed a few years ago. And I've been kind of thinking about how my training has gone over the years and why I've become more compressed. And it's funny you mentioned foam rolling and rolling, because I used to do more of that.
Mm-hmm.
And I was thinking, by the default, maybe that's why I wasn't as compressed. But just in my mind, I was thinking, from working from the inside out, could like a training intervention of more heavier lung activity, like an interval on a bike, or I'm just using that as an example, could that have led to more expansion? Because I was actually, working from outside, like my lungs were expanding more. But would you be thinking that there'd be concentric? It would just increase. Yeah, okay, that's what you cleared up there. That would just feed more into concentric orientation, which would make it worse.
Relative motion.
Yeah.
Coincides with normal tidal volume.
Okay.
Not forced inhales and exhales.
Okay. Yeah, perfect. There's a nugget for today.
There you go.
Thank you, sir.